artificial intelligence help a surgeon prioritize a massive caseload? So we're going to look at the legal and the clinical accountability of these systems. When a machine helps decide who is responsible. So there's lots of considered questions here. So let's bring on our panel of experts. So firstly, we've got Dr. Devesh Sinhar, Chief Clinical Information Officer and Lead Consultant Stroke Physician at Barking, Havering and Redbridge University Hospitals NHS Foundation Trust. So welcome, Devesh. Thank you very much for joining us. We've got Neelan Das. He's Clinical AI Lead and Consultant, Interventional Radiologist at East Kent Hospitals University NHS Foundation Trust. So welcome, Neelan. Thank you so much for joining us. And she's a super sub, is Dr. Bex Winterburn, Clinical Director, NHS at Home for Bristol, North Somerset and Gloucestershire. She's also Governance Lead and Vascular Surgeon by trade. So welcome, Bex. Thank you so much for joining us.
Pleasure.
Right. Wow. Where do we start on this? I think this has been such a huge topic for everyone at the moment. It's really been something that everyone feels quite passionate about, and with loads of questions about it. But when it comes to AI and it comes to triage, I mean, gosh, where do we start? I'm going to start with Devesh first. I mean, is AI a priority right now for the work that you're doing? Is it something that we should be focused on, the NHS should be focused on? Or is it something that we should be, okay, we've got other priorities right now?
Thank you, Gail, and thanks for having me. What a fantastic panel. I'll echo that. First of all, is it the right time? Yes, definitely. I think there's a huge opportunity looming in front of us, whether we grab it with both hands and that make a best of it. Are we a bit late? Yes, we are. I think we have to admit that the health itself have been quite challenging in terms of that accountability piece that, oh, well, AI is touching everything, but are we allowed to touch the health? And that probably the connotation was there for quite a few years. But we have proven so well that if you use AI in a trusted, safe, and governed method, there's nothing else which can solve the current NHS challenges and problems.
Okay.
And I just give you example. It's just not like a triage call, but I think just what we actually using in practice and as a CCIO. So first of all, one of the things we use Brainomics, and Neelan probably knows more than me. I think there's an AI triage where actually we can see the image and decide whether this patient need surgery or not. And 4 years down the line, this is probably the first AI which has been used as a role model or used in NHS or NICE guideline that it should be used.
Yeah.
Again, a very good safe use. It reduced the time the patient receive care. So the stroke is the emergency, and if I reduce the time around 78 minutes in some cases, I think that's the kind of AI we probably are looking for.
Yeah.
Some of the triage and other things, Gail, I can go on and on about the predictive analysis and how we get the people in, right people in, so the waiting list is right. And I'm going to say, and just finish there, Gail, is that we all in the queue in NHS. What AI can do for us? Are you in the right queue?
Oh, are you in the right queue? I like that. That is a very good point. Neelan, I mean, Devesh so obviously pointed to you saying you're in the right place to sort of talk about this. When we talk about queues and places, have we got a system right in the NHS at the moment that can help this to make sure we are in the right queue?
Well, I think, I agree with quite a lot of what Devesh has said, but I would disagree with the one thing that, are we too late? I don't think so at all. In fact, I think we're in a brilliant place, the NHS. I know in America, for example, or China, where we all get compared to, it's just gone, really rapidly, but it's been quite heavily deregulated in a way with the latest FDA guidance. And that can be a good thing, but it can also mean that you've got a lot of sort of Wild West type situations coming in, and we can't really afford that in the NHS and healthcare because it's a taxpayer funded system.
Yeah.
Well, whether they can afford it in America or not is also another question, because individuals end up paying for it. But in our system, we it's like everything. We've got a lot of inertia in the NHS, and that is it. That's with every single thing that we do. But we have a bit more integration than other fragmented systems. I think the latest, the CERSI initiatives, the latest sort of NHS guide to AI buyer's guide, has done a lot to help not just clinicians, but those in the management systems of hospitals to try and feel a bit more comfortable getting hold of these potential off-the-shelf solutions.
Yeah.
We're in the right queue, if you ask me, but you have to get the right team together. And for 7-8 years as a clinical lead in AI in East Kent, I started just on my own. I had no secretary, no PA, and I was badgering people on my own. And I finally, after 4 years in the middle of COVID, got an AI chest X-ray system deployed and validated, which was the first one in the country to be done. But it took an inordinate amount of effort, but that is now going down, because now, for example, in East Kent and many 16 or 17 trusts, we've got an AI deployment platform, a bit like an app store. So for imaging based algorithms, you can deploy them quite easily because all the integration's taken care of. But nevertheless, we still run into challenges with that, because who's going to do the validation? So there's a lot to talk about on that side of things. One thing right now in radiology, and I think this applies to every sphere of medicine, you've got ambient voice technology, of course, as well. You've got to look out for algorithm drift. You've got to look out for automation bias. So it's how do we monitor the system? Now, for me, the big question is not, is there a solution, but how do we monitor the solution? And how do we make sure it continually is performing well when it's dealing with thousands and millions of events in the speed of seconds? Whereas before, you monitor a human, they're really slow. So you can get a handle on how they're performing. One error could be magnified into 100,000 cases before you realize there's an error.
Exactly. And we've mentioned this before. I feel like there's an irony, because people think that AI is going to save this and save time and save it. But actually, you need a team of people to enable the AI, to work with the AI, to process the AI, to interpret all the data. And people, do you feel that there's, Bex, I'm going to throw this to you. Do you feel people are thinking that this AI is going to solve, the world? And it's like, well, no, because actually you need, as Needham said, you need a team of people. What an AI is not going to just do it, because like you say, that one tiny thing can then go so far down the road, and then it's like, oh my gosh, we've got to come all the way back, or it may be too late. So is that one of the biggest messages that we need to sort of get out there, that it's actually about a team of people with AI?
Yeah, I think what Dev and Neelan have done here, they've started as the trailblazers. I know Dev describes himself as the trailblazer, and Neelan, having started 9 years ago and having that foresight that you need someone that starts off as one person. It's like the dancing man field analogy, isn't it? You have that one person dancing in the field, you get your first follower, you have the people that are adopting it, they'll always be the laggards. But how do we show people that it really does need a team to make this work? It can't stay as a nice to have. It can't stay as I don't believe it should stay just as a nice to have, or as a, something that's happening over here that isn't happening over here. But we need the infrastructure at all levels to make it work, to make it safe, to have the clinical governance, the safety governance around it. And then it's, where does that, who is holding that risk? Is it the companies who are providing the solutions? Is it the organization that is implementing the solution? Or is it the clinician, with the patient in front of them, that is holding it? And how do we work through each of those stages? And I'm sure that Dev and Neelan have had kind of first-hand experience of that through.
Yes. I mean, Dev, when Bex was talking like that, in my head, I was like, oh my goodness, there's so much more to this, isn't there? It's just, again, it's like people think AI is this quick fix solution and everything will be right, but no, I've actually just gone, oh my gosh, I wouldn't even know. Where do you start? I mean, what's your point on this? Because, what you want to have a positive view on an AI and how much it's working and how much it's helping the NHS, but is there at the back of your mind that risk at the same time when you're working with it, or can you trust it fully?
I think personally, I have a positive outlook on it.
Okay.
With a governance hat on, with a safety and quality hat on, yes, we need to be aware of that. You've got to think about what goes in and what comes out the other end. You're relying on the inputs to create the outputs, and then understanding how it is learning to change those outputs. You've got to think about unintended consequences. But for me, it's like introducing any new thing. I don't think we should think about it any different. You go back to when we were all at, medical school and before. We didn't even have the internet,
I was just about to say that, Bex. Should we treat it like a trainee doctor? Should we treat it like a support system, like someone who's learning? Should we see it like that?
So if I can come on that, I think we have to be optimistic. Otherwise, we wouldn't be doing this job. We all are. I think we are optimistic people by trade. If you love digital, so the few things. There's a need for governance, and I totally agree. And I totally agree with Nilan that this should not turn into the Wild West. But we have to curb the itch of controlling it too much as well. And the reason I say so, 5 years back when the bank apps were coming, I think we probably had that itch. Oh my goodness, my money is going to go somewhere if I use the bank app. And look where we are. So we have to create the governance structure. So many trusts are doing it. For example, we had our AI and ethics group, exactly same the point Neelan and Beck mentioned, whether these algorithms are fair, whether they can have your all the question answer about ethics, equality, and that's a very important thing because that brings the trust. But at the same time, we cannot simply go and try to curb, which is this is inevitable. I think the AI is going to be in every curriculum of medical student or trainee. You just mentioned that, Gail. It has to be empowering the people on the front end. So the reason I say so, because what I'm seeing as a CCIO is that, and Neelan is right, that is driven from market. Oh, here is a kit, do and use it wherever you want to use it, and let me know what the product is. What should happen is the people who run the front door and know the processes, they are empowered with that knowledge, skill set of the AI, and now they are your almost like co-designer where these AI should be used. And you pick up any successful example of any AI use in NHS, you will find that trait where it comes from the people who work in a floor, know that I can use that. So we should focus on empowering that knowledge and time and the training for the frontline people to adopt AI and let them play with it.
And I think that's really important when it comes to triage as well, because again, when it comes to those high pressure decisions, you have to have the people that are involved in the front line to say, look, this is where we're struggling. This is where we need help. This is the problem. Please help us find a solution. Because I think, no one, sort of no supplier coming in and going, oh, we've got this fancy thing and it just, it doesn't work. It will create more problems. So this is definitely something that when it comes to, like I say, triage, this is where the priority's got to be, hasn't it? When that comes to the co-design of that. And is that done enough, Neelan? Is it co-design done right when it comes to triage and AI?
What I can see so far is there's not enough co-design, just to be black and white about it. Really, a lot of companies have, if you're talking about companies, have engineers building things and they've heard about a problem and think that they might be able to solve it, and suddenly they build something, they spend a lot of money on it, and then they've got to get return on their investment, so then they're pushing to sell it. But the thing is, rarely do they have on the ground clinicians. Yes, they might have medical directors, but they don't have the on the ground clinicians really feeding into that, because they would have to then pay those clinicians or that trust to do that, and that's where there's a gap. So that's my feeling and my opinion, and what I've seen with quite a number of radiology based companies anyway. But I think they're realizing that It's like everything, you know, it's been the Wild West over the last 7-10 years, but they're now, a lot of those companies are folding, and they're not making it. There's a sort of narrowing of the market, and that means those that will survive will be the ones that from the ground up get the clinicians involved. So it's going to happen, and it is happening more and more. What we found in our trust was that we had a couple of companies not related to radiology come offering us solutions, charging us the earth, and then our data science team actually built it within 2 weeks themselves.
No way.
So, you know, you can do it.
Email. Did you just send them? I'd just like to say, we just want.
Well, I mean, it was an idea we had, and then, you know, it was you know, what you'll find in big organizations, you've got silos, and then you're already doing something in the trust, and someone's gone off to a conference thinking, oh, there's this great thing. They come back with it, and then in the end, you realize you might be able to do it yourself. There's pros and cons to doing it yourself because maintenance and all that. So there's definitely a need for small to medium enterprises, and I support the growth of small and medium enterprises because that's where the innovation comes from. Unfortunately, what might be happening is small and medium enterprises then come in, they might then you know, the big players get a sniff of it and then buy them up or close them down and do it themselves. So it's really a difficult place for that. But I think that more and more the clinicians on the ground are getting involved because, you know, the atmosphere or the environment requires it, and people are more aware of it.
Do we encourage that? Do we have that culture of sharing, you know, what that's, you know, Neelan's just said there, Bex, like, you know, we want that. We want these innovative designs. You know, do we have that sort of ability to do that, Bex?
I think it's getting better. I think that idea of collaborating and sharing across is much better. Coming back to Neelan's point there around the big companies and clinician involvement, I think it's also, you know, recognizing that there's so much entrepreneurship and innovation within clinicians who are working. I'm working with a surgical resident at the moment who's got a brilliant idea that she's putting into practice. We're looking at how we then test that with her in a safe way. And again, this is around triaging patients and identifying patients suitable for acute care at home. And it's, you know, it's championing those and making it easier for them to navigate all of the hurdles of trying to introduce innovation. Now we've got, you know, fabulous health innovation network teams now across the country who can support. But I think that's, you know, it's another reason for optimism, isn't it? The challenge then is holding on to that resource and not allowing it to be sucked into a big company or the ideas stolen by somebody because someone hasn't understood how to maintain, you know, copyright and trademarking and patenting of an idea. And that's what we're not perhaps as good at as clinicians unless we're working in that space or interested in it.
It's not your job though, is it? You know, it's not, that's not your role, but it should be easier. And this is, again, you know, someone's got this innovative idea, someone's got a solution to a problem, and then you get red tape and you get restrictions and regulations. And then, I mean, you can tell me, how long does it take to get an idea into actual practice? And then what happens? I'm guessing technology moves on, there's another idea, and is this what it in real life, this is what it's like? Or does it get, are you in positions now where you actually can see the things that, you know, you were talking about and it's quite quickly implemented in? Devesh?
Yeah, so the truthful answer is not quick enough.
Okay.
And again, you know, we talk about bureaucracy in digital, and I just want to share very quickly, Gail, very honestly, openly and candid here. I used to talk about that. Well, I have my vascular surgeon who has a fantastic idea. Let's go out and implement that digital kit. And suddenly realize that we have now digital safety, we have DCBs, we have DTEC, we have DPIA, we have DFD, and we have, so we are that bureaucracy somehow.
Yeah.
And that was quite an introspective moment for me. Actually, what I really hate, I am part of that. and that eye-opening, and I'm very open with you and very honest with our panel here. I think So how can we change that dialogue?
Yeah.
So how can we change that dialogue is that let's harvest that innovative minds within NHS, and I can read some question coming on that same theme, and provide and facilitate that journey so that it does not come across as hard and arduous. What you classically see, and we all have seen our example, people get fed up after that innovative idea not being materialized into anything, and they either move into some other sector and we lose them forever, or actually their idea is, well, it come to fruition after they lose themselves into this.
Yeah.
To get the thing something done in NHS, you have to have really good resilience, because every door which comes on the way is good close to you, and it's going to close on your face. But I have a lot of hearts and minds and praises for the people who get the things done within NHS despite of all the red tape we talk about.
Yeah.
So the summary is, we talk about red tape, but we might be red tape ourselves. Help and facilitate that, and ensure that they stay in the system.
I'm going to put my other hat on. Not that I have much of a governance hat like Bex, but I have, the other side. I'm going to be the voice of doom a little bit, but we have to think about the safety side. And, that is something that, okay, that's why we have these horrible red tape and bureaucratic even systems in place, because what happens if it goes wrong? And this is it. This is what we have to say, because we live in a world. I mean, it's bad enough when there's human error, but if there's a technology error, then all hell is going to go. It's going to break out, isn't it? So what happens? I mean, talk to me now, because I've not realised how this is much of a concern this could be. And where is it? What's the reality of it? I mean, we've got AI system, AI innovation coming in, helping out. It goes wrong. What happens? Whose fault is it? We mentioned that. Or is it anyone's fault, or do we just have to accept that we've just all bought it together?
Can I come in on that? Because I wrote a paper on ethics of AI deployment, and that included the liability side of it. That was many years ago, actually, 2018. But I think it still stands. But right now, if an organization, there's two things: it's commercial or it's R&D, and then it's your own software that you've launched. Okay, if it's commercial, well, either way, both of them actually lead to, ultimately, it's the organization that carries the risk. You might get reputational risk for a company that has a problem, but the organization carries the legal liability currently to pay out if it ever got to court won. But I don't think, as far as I'm aware, we've had a test case yet where there's been a significant error. But we're not as widely deployed as people think, AI. Hard, actually. So it's still to come and be tested. But right now, the taxpayer pays for it and the companies make the profit. But that's been the case with all IT stuff. Although I think this is not different, but it's amplified, okay, and faster, the rate of it, as we've already alluded to. But essentially, I think at some point there will have to be a risk sharing model, because really, with a consultant, yes, the trusts take the vicarious liability, but you still hear of cases where, unfortunately, physicians do end up in court and get penalised. But so there will be some risk sharing there at some point, when the test cases come. But as most law here is made by precedents, I think that is the way it will happen. But you could do risk sharing, and you could do pooling. You could get companies to pay into a pool and then pay out, but you'd have to change the whole model of payout, probably in the NHS, where X amount of damage leads to X amount of payout. But that's a big problem to fix.
Yeah, that's huge. I mean, Bex, you are a governance lead as well. I mean, this is something that you're it's not, you don't want to think about it, but there is that accountability and safety as well.
Yeah, I think absolutely. And I think again, to kind of think about take AI as a term out of it.
Mm.
You know, we're grappling as a collaborative service, having developed an integrated shared governance model that people sign up to. Now, we haven't had a test case that has had to put that into action, other than, of course, learning events, you know, and then we use the patient safety incident response framework to drive the way that we review those cases. I think the opportunity here of having these conversations and the dialogues around AI is that you build a similar infrastructure. Again, if you get the infrastructure right, it gives you the freedom to work within it. It goes back to what Dev was saying earlier, doesn't it? You need some kind of structure, but you don't want it to be so rigid that no one wants to get inside it.
Yeah.
So there needs to be enough of an infrastructure that gives you the freedom to expand and evolve. And the way that we talk about risk used to be a very, you know, binary human error.
Yeah.
We're much more a systems approach.
Mm-hmm.
We now have to add in terms of that digital part of the system we work in, AI is a part of that, and how we work through, you know, it will never be one particular thing. There will always be multiple events that lead to an error.
Yeah.
So it's about how we describe that as part of the governance models that we develop. But that shared risk, shared responsibility, courageous approach is very hard for some people to deal with. You know, all of us sat in this room are actually at a high-end risk scale in terms of the specialties that we're in. So we're quite used to dealing with risk.
Yeah.
Many other people aren't. And so risk appetite amongst clinicians, leaders, managers, you know, other healthcare professionals is vast.
Yeah, that's a very good point, Bex. Actually, like, yeah, it's got my brain going. Actually, it really has, and it's like, but if you don't, so I'm going to use the Spurs logo. You know, Spurs, Tottenham Hotspur is my team. Unfortunately, they're doing rubbish, but they have to dare is to do, right, which they have done nothing of that this season. But anyway. But you have to take an element of risk. If you, otherwise, we're just going to stay in the same place, aren't we?
Yeah.
And this is it. And it's trying to get that message out there, isn't it? You have to do something, otherwise.
Well, I think you're right. I can just come in, but the most important thing I think right now is how you develop your risk management system.
Yeah.
So as I said, in radiology, there are now automated solutions to look for whether you've got spikes in errors. It's just AI monitoring AI in a way, and then some, but it filters it down so it's more manageable. And that's what's got to come.
Yeah.
So AI monitoring AI. Okay. So, but what can a human spot a problem as well? Is there a human override?
Yeah, there is, you know, but what will happen is, you know, you get dashboards summarizing. So you can say like, the last 3 days, there's been a spike in radiologists agreeing too much with the X-ray report, the AI generated one. Why is that? Or suddenly there's been something's happened where 1,000 chest X-rays weren't processed by the AI. Why is that? Oh, we got a new X-ray machine in, and that it seemed to throw the algorithm out. So differences in hardware can lead to impact the actual algorithm, because there's subtle differences in the digital metadata going into the algorithm. So that can throw it out. So you have to have all these posts. It's not just with imaging. I think any tool which is automated will face that. So if you get an upgrade to your Windows 11 to Windows, don't know what's coming, 12 or 13, so how's that going to affect the systems, you know? So it's all that kind of thing.
And again, it's just that team of people to support. Yes, Devesh.
Yeah, so I just want to supplement what just Neelan said. It's quite interesting how NHS respond to the risk. Usually it's a lovely A4 page which has green and red and amber boxes, isn't it? We all know that. Unfortunately, you are checking AI, which actually is far advanced and actually fool your red green sheet very easily. So what do you need? What Neelan mentioned, you need AI checking AI. And I just say we have our ethics group, which we go through every AI coming in, and we set up the board. And what we'll end up doing, Gail, is there's an AI which checks the ethics of another AI, whether you fulfill it or not. And it's called as, you know, the ethics box or ethics tools. So we'll end up in a situation where AI checking AI and doing the function. In terms of the risk, we are at risk profession. Beck says that although we three are on upper end as a panel and we're biased, but as a profession, the medical profession is a risk profession. You always have risk. Is how you manage that risk is the question. You will not work in a risk-free environment ever.
Absolutely. And I think that's something I think has really come across today. And I think I love the fact you guys have sort of emphasized that as well. I'm going to move from triage to virtual care and virtual hospital models, which, you know, I'd never really have heard the term virtual care or virtual wards before I've been doing these conferences. And of course, it just makes sense more and more now. I mean, I mean, in my eyes, and you know, you're the experts here, it's less risk. Okay, you're not sort of dealing with that, you know, intense, high, you know, situation in triage. But for instance, is that something that you see more and more, the AI sort of helping your work case, your workload? The AI is going to support that and support the patients in the best possible way. We're going to see more and more virtual hospital models, Bex?
I think it's really interesting that you say that it's not something you've been aware of until you've been having these conversations. You know, they have been around for quite a long time, and there's a misconception around the acuity of patients that we care for in that environment. And in our service in Bristol, North Somerset, South Gloucestershire, you know, we are providing acute care at home as an alternative to being in hospital. There is then a level of virtual care, which is more around how do you, for example, you know, clinics and being able to proactively monitor and manage people so that they don't have to, you know, trip up to hospital and back for outpatient appointments. You know, it's one step on from telephone appointments. It's the remotely, you know, how are you feeling today, or how are you feeling at the moment? What's changed, and keeping an eye on that. So I think there's a wealth of opportunities. And then it's how you use all of that information together to provide proactive care for people. So I heard you talking in one of the other sessions. Locally, we're working with some researchers around kind of an idea of almost like a News 3 score, where it's not just about patient observations, it's not just about clinical symptoms and how people feel, but how do you pull in information about their social situation and their care support, and you know, imagine a Rubik's Cube of parameters that feeds in to help you to stratify risk, forecast patient care, but also then loop back and provide the proactive care that people need so that they can take ownership of their care. So I think the possibilities are endless. And what I suppose, you know, with my positive hat on, you know, you kind of hope that you do that releases time to care, releases time for the really human interactions and conversations that we need. I think we've got a long way to go, but I can see how. But then you've got the challenge of the poor integration of digital systems that we have currently. And we're using the secure data environment to do some work around this. But even then, you're relying on what's being fed into that environment.
Exactly. So, yeah. And I, you know,
space, but yeah.
I love that 360 approach as well to the patient. I think that's a really great, because it does all matter. And I know what people are like. People don't tell you everything, do they? They lie to you. They don't tell you the truth. Dev's like, I know. Dev, what's your, you know, with virtual hospital models? I mean, it surely must be helping you with patient care as well.
Yeah, I think this is essentially, as Beth mentioned, I think, and she was alluding, it's a new way of working, is a pathway transformation, and it's actually very little digital in this, you know. And I'm being very honest, and I will explain why. Because there is a need for NHS to work differently. We haven't got so many beds which is vacant. We have more patient, more demand, and there's demand and supply. And it's all about new way of working. So if I have the patient who is well enough to go home, and I can make a simple telephone call and talk to him, that's a virtual care. That's a virtual home care for me. Now, I can add extra kit on that. I can ask patient to write down how he's feeling today morning and run the natural NLP or language processing over it. and give my nurse brief or virtual nurse brief. This patient is showing some worrying sign and you have to address first. Or I can put another 30 set of monitor on the patient, and then that give me that information. But the digital is the least part of the virtual care, and that was happened to us. We have 30-bedded virtual ward, and we started with that big bang of, oh, we'll have the kit and this and that, and we'll end up with the patient going home and nurse making a telephone call in the end. And actually, that's not a bad thing. And the reason is not a bad thing because you transform the way we work. We transform the pathway, and now we are in a second layer. Now you can help the virtual care with the digital and AI help for the people who can engage with it, and you have the alternative pathway for people who can't.
Yeah.
So that's my personal journey on virtual care.
And I think it's this bigger picture, and I think the public don't realise about the bigger picture sometimes. Again, they just expect me. And actually, when this is why I've loved doing these hosting conferences, because I'm like, oh my goodness, it makes so much sense, you know, blah 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 blah. But so many people don't know this. And that's the problem, isn't it? It's getting everyone on board. It's the clinicians, it's the surgeons, it's the nurses, it's the frontline workforce, as well as the public, to be part of it. And because we do need to do something, we do need to transform it, the NHS, because if we carry on doing what we always do, we'll always get what we always got. Neelan, so like, is everyone prepared for this journey of AI and the NHS? So we, when it comes to triage systems and virtual wards and everything, are we ready for this?
Is anyone ever ready for anything? It just happens, and then you become used to it.
Neelan's born ready. You're born ready. Yes, I know. You're right.
Well, I mean, it's like it all, like 5 years ago, no one was ready for ChatGPT or Claude, and suddenly everyone's using it.
Yeah.
So, you become ready when the things are available. The main thing, I think, with all of digital AI, whatever you want to call it, is actually what we've been doing in Kent is getting patients really involved in it, to make sure you've got they're actually the winners or the losers from this. So they need to be heavily involved and give their opinions, and that's where the UK can really shine, because we kind of do, I think, public patient engagement a lot, sometimes too much, but I think it can really help there, and that's where our strengths are. And when we get the ideas from them, from our people we care for, that's where we'll really win out. And the other point I wanted to make is, you'd hope these things would free up more time to have those good conversations that we always wanted to have. What we found in the community when we brought in ambient voice technology for the GPs, it did help initially, and then but it wasn't the case. Suddenly they had more, because there's just such a massive amount of patients. They just had to see more patients. So actually what you've got to figure out now is how you deal with the cognitive burden. So yes, you've got 30 patients suddenly under you. You're not having to do maybe as much physically, but suddenly you've got 30 patients. That's so quick. The information's coming. How are you going to manage that and make those decisions really quickly? So that cognitive burden you've got to factor in, I think. But definitely, I think I feel positive about it. And we're so at the beginning with large language models and vision language models. You're going to find, hopefully, that a lot of the bureaucratic side of it can also be taken care of.
Yeah.
And that's what I'm optimistic about. So Dev, you're talking about all the DCBs and things. Well, there's a plethora of things coming out where the DCBs just be done. You have to quickly read through it.
Yeah, and it's incredible. It's I think about that. But let's finish. We've got 5 minutes left. I want to finish on a sort of positive, and let's think about what now and the future. So when we talk about AI triage and virtual care, Bex, will go to you first. Sorry, I'm picking on you first. For you, I really want to kind of message the support out there, because there'll be lots of people listening going a little bit wary, a little bit unsure, but just giving that kind of like advice message, saying, right now we're here. This is what I'm doing. This is what I'm seeing. But in the future, it's going to transform this, and this. From your opinion, what would you say?
I think I loved Dev's phrase earlier on, are you in the right queue? So I'm leading a piece of work at the moment with colleagues around urgent care coordination. And what we find is that, of course, the easiest route is to end up in an ambulance and end up in ED, but that for the majority of people is not the right queue to be in. So if we can use this technology to support us alongside, shifting finances, recognizing where is the right place, right person, right clinician, all of those things, getting it right the first time, that's how I think, AI can support us in terms of triage. And then in terms of the virtual care, really interested to hear Neelan's point there that yes, initially you kind of feel like it creates more time. The challenge is we then treat humans like machines and say, well, you can work more and work harder. That is not the answer and the solution. We need to be supporting clinicians. We need to be supporting clinicians' well-being and time to think, because we've lost a lot of that. We need the time to think and process. We can't just cram more into the day and be asked to do more. And we can't use AI and technology as an excuse to make humans work harder.
Yeah,
so that's my plea. That's my message.
Keep this brain, keep this person. This is that's exactly
well. It's you're so the workforce. We need to be cognizant of the workforce, and this can't be a way of making the workforce do even more.
Yeah. And there was something, I can't remember who said something, and I just instantly thought of the reliance on AI and getting lazy with it. And I was like, no, we can't do that. We still need to keep this.
It's an enabler. It's an enabler.
Exactly.
Yeah.
Thank you. Neelan, for you, where now and the future?
Now it's about system transformation, but it's a big job. But if you get to that point, all these things need good integration and workflow change. That's how you change the pathways and improve the pathways. And the future, well, let's see. I mean, you might actually have robots, physical AI doing a lot of work. So then that might free us up even more, but we'll see. How long into the future? You've got 5 years, 15 years, 100 years. 5 years from now, I hope to see that we've got a good system for, as I've said already, monitoring, so that it actually frees us up to implement some solutions. And 10 years from now, I'd hope to see it really working just in a really integrated manner.
Yeah. And someone's putting a question about Tottenham Hotspur manager. So maybe we could have a robot for Tottenham Hotspur manager because we're doing that bad. Or maybe replace the team with robots. I'd be quite happy with that right now. No laughing, Dev. I'm a suffering Spurs fan. Dev, and to you, I mean, the work that you're doing is absolutely incredible work that you're doing. The insights is invaluable that you are there on the front line. And for you, obviously, that's a message out there to people who are a little bit wary, a little bit concerned, or they've got ideas for now. And then also, how do you see AI with triage and virtual care, say 5-10 years down the line?
Yeah, no, thank you, Gail. So first of all, now for me is a bit of help and support and centralize the thing. I think we think NHS is one, but it's not. We got 200 odd NHS trust trying to do the same thing, trying to overcome same challenges, but probably replicating or triplicating the same process of approval, innovation, and rest. And I'm fully aware that MHRA and NICE are coming with the framework and rest. But somehow we need that central repository now, our central approval process, or the central processes, which takes away this kind of burden, which is resource constrained NHS IT and the digital and the clinical world to not every trust need to do this. These are the kits, these are the provider, and these are the things which can help your common challenges. That's now for me.
Yeah.
And that will take away the things which you just talked about quite a lot. And the future is that we empower people who actually do the work. And I'm glad today I just heard what I see in my clinical floor. And I quite like to see this happening in ED, happening in outpatient where triage happen, I wanted to see in my virtual ward, where people who run those pathways are fully competent, capable of running AI and automation and doing the deed what need to happen, rather than coming from the product literature.
Yeah.
That's the future.
Love it. Love it. My gosh, it's been so insightful and so interesting. Thank you so much. We've seen today that digital transformation isn't a destination, it's a culture. It requires us to be brave enough to change the way we've always done things to ensure the National Health Service is here for another 75 years.